pediatrician since after COVID 2019. So I may be a little bit rusty in that sense. So you might have to verify some of the things I say if it doesn't sound right to you, either by asking me or asking someone else. So let's start the lecture. I plan to do two things today in the 2 hours. One is this lecture called The Care of Child from 0 to 5 years. I highlight the main areas that as a general practitioner or a family physician you have to be interested in. Then I will actually do, because Praneeth asked me especially to do it in the form of sort of case history and with MCQs, I will do a case history which actually I developed for the SLMA for sessions on an infant with diarrhea, which has many MCQs in it. So let's get ahead. Now the period, the childhood, I have divided into certain areas. Of course, firstly, we start with the newborn. Newborn is defined as from 0 to 1 month. Early newborn is 0 to 1 week. Now, during the newborn period, there are several really important things which, as a family physician, you have to be involved in and supportive of. Of course, the most important among this is the establishment of lactation and continuance of lactation. This is absolutely critical. I mean, when we were students, uh, almost all the mothers in Colombo formula fed their children. Right. I mean, sometimes in addition, sometimes exclusively. But this has completely changed now when the world recognized the importance of exclusive breastfeeding. And now, globally, 0 to 6 months, what is recommended is exclusive breastfeeding. That means only breastfeeding, nothing else except for water, etc. Even water is not essential if you adequately breastfeed. And of course, medications, if really indicated. Nothing else should be given. And this is a well-established fact, and it is followed globally now. And I must say, Sri Lanka is one of the countries which has the highest rate of exclusive breastfeeding. But we must support this and try to increase this. So there is a major role for a GP in this, because motivation and not prescribing formula feeding at the drop of a hat, merely when the mother comes and says, my milk is not enough, that is something that you should not do, right? You know, you have to, when a mother comes and says, my milk is not enough, there is a way that you should set about. First of all, you must see whether the child is gaining weight. If the child is gaining weight, then obviously it's not wrong. If the child is not gaining weight, you have to consider, and there are certain things you don't straight away prescribe formula. That is the last resort. And even when you prescribe formula, you give it in addition to breastfeeding. Therefore, it should not be, you should never suggest alternative breastfeeding, and formula feeding should be a top up after a breastfeed. So very often babies don't take it. And the other thing is the way you give it, it should never be given through a bottle. Because if you teach the child to suck from a rubber teat, he gets used to it and then he doesn't suck the nipple. So it should always be with a cup and spoon or some other method or drip feeding, you know, and only as a top up. So only very rarely is it indicated. I can tell you in my practice, hardly any. I must say I have I don't recommend one thing for my patients or one thing for my family. Everybody, I mean, who faintly connected with me, the babies, I have managed to motivate them and to continue with exclusive breastfeeding. And in my mind, as a doctor and a pediatrician, this is an even greater measure of ensuring current health of the infant and the future health of the child, even more than immunization, I would say. Immunization comes a close second. I think exclusive breastfeeding to me is one of the most important ways of ensuring that the child remains healthy. Okay, so that's all I will say about that at the moment. Then neonatal screening. Now, these are very important concept which has become very, very important now. That is screening for disease. You know what screening is? That is looking at a large population for any signs that there may be a illness and then intervening there. So there are several things that can be screened for in the neonatal period. Actually, there are a large number of things, but we can't do all of them. We'll talk a little bit about what is available and what can be done. Then, of course, the most important problem, the pathology or the illness that you get in the neonatal period is sepsis. Sepsis means infection. As you know, immune competency of the neonate is limited. They are still developing it. Therefore, when they get even a local infection, it spreads very quickly and becomes sepsis or septicemia. So you have to take a fever and any signs of sepsis. The most important sign of sepsis in the newborn being refusal of feeds very seriously. You can't sort of tide over it. You can't give paracetamol and wait and see. And you definitely should not start antibiotics empirically, which was a common practice among general practitioners in the past, oral antibiotics. That is certainly absolutely not on. Don't prescribe antibiotics to a newborn without establishing a diagnosis. So, neonatal sepsis is still common and can be quite serious. So, you should suspect it the moment a child goes off in any way, stops feeding, uh, or gets fever, or sometimes they get even hypothermia. They stop gaining weight, suspect it, and then you have to act immediately. Actually, you have to screen. There are ways of screening for sepsis, as you know, C-reactive protein and a full blood count, and of course, clinically. But if there is any suspicion of serious sepsis, the child needs to be admitted because antibiotics cannot be given orally during the neonatal period. If you think it is sepsis, you have to really treat with intravenous antibiotics. Then the other very common condition in the newborn period is jaundice. As you know, every neonate will have a little bit of jaundice, what is called the physiological jaundice, due to breakdown of the excess red cells. But this is limited, and then when jaundice is persistent or severe, it becomes serious. So you have to know how to recognize serious neonatal jaundice and what to do about it. Again, if the treatment is delayed, there is a danger of kernicterus. I must say we used to see that a lot in the past, but not any longer because most doctors are quite savvy to treating jaundice and recognizing its dangers. So, of course, the very effective treatment is phototherapy, and that's available in almost all the hospitals around now. So we should so the main thing is to decide whether the jaundice is pathological or physiological. That is your problem as a GP. So you have to really, and then also jaundice becomes more severe. Now you can notice that one thing that doesn't occur in this list is prematurity or preterm birth, because that is mainly management is a very a hospital-based thing, and the GPs only get involved in it after they are discharged. So that is why it is not in the list. But if they are preterm or premature, then all these things, sepsis is more dangerous, jaundice is more dangerous, things like that. So you have to be conscious of that, right? Okay, neonatal jaundice is an important subject. Then there are several minor problems in the newborn, which are very much in the province of the general practitioner. I will talk about them in a little more detail later. And then, of course, the most important thing is even in the newborn period is the commencement of immunization. As you know, BCG is given before discharge from hospital for most babies. An occasional one may miss it, in which case they should get it as soon as possible after discharge. And then, mind you, uh, uh, counseling about family planning in the sense planning the family. That is a part of pediatric care because if the mother conceives too soon after, it's not limiting the family size. That's a different thing. It is a absolutely personal thing up to the couple. But spacing is mandatory for everybody because if you don't space, it's not good for the mother as well as the baby. So you have to be involved in all these things as a good family practitioner. So I told you now, my data may be outdated. Now, this was an extremely good book from which you get cancer published by the Perinatal Society, called the Trainer Guide to train people, especially these are training non-medical people about how to advise mothers. In this guide, you get a lot of information. But this may be old, there may be a more updated version now. So now neonatal screening, I told you, there are several things. Again, the list has grown very much now. Uh, the the standard thing that even we all did was a clinical screening, which was by doing the autolanase test. Every baby before discharge was tested for congenital dislocation of hip, because that's a condition. If you don't treat in the early phase, the disability, the residual disability gets treated. So we used to do this autolanase test. All of you should know how to do it. And if there is the slightest suggestion of a click, we used to refer them. Uh, those days we used to do X-rays. Now X-rays are not needed. You can do ultrasounds and refer for orthopedic opinion. Right? Okay, congenital dislocation of hip. That should not be missed. Then congenital heart disease, of course, that's also clinical. We used to listen carefully for murmurs, and we used to check for all the pulses, especially the femoral pulses. If there is any abnormality in these, we used to refer for a pediatric, now maybe straight away for a cardiologic opinion. Uh, uh, I mean, I think and also if the baby is a syndromic baby, that is with other abnormalities, then congenital heart disease is very much a possibility. And there are certain circumstances which congenital heart disease is more likely. And so you have to screen for this and detect it early. And now, I mean, if there is a slightest suspicion, they will do an echo and then follow up themselves or advise you regarding follow up, right? Okay. Uh, yeah. Now checking for vision, which we did, now especially important in preterm babies. That's done in the hospital, and especially if they have been preterm, they'll be referred to an ophthalmologist to make sure that there is no retinopathy of prematurity. Hearing, we did not check for hearing in the neonatal period in the past. Now it is possible to check for hearing even in the neonatal period if there is any doubt. If there is any doubt, there is in fact, I'm not sure. I don't know whether you have. I think in some hospitals they are screening for hearing in the neonatal period. You'd better check on that. It is possible now, right? Okay. Of course, the biochemical testing. Now, I worked in Saudi Arabia during my sabbatical, and that's a country where consanguinity is extremely common. And due to that, there are a large number of serious metabolic disorders in the country. So I got used to seeing serious metabolic disorders in the neonatal period, and I began to appreciate the need for screening through that. But of course, you can't screen for all these. And the one that was really important even in our country, because we had a lot of congenital hypothyroidism, which was missed in the sense it was diagnosed only at about 6 weeks or so, which is very, very late. Actually, if you miss the congenital hypothyroidism in the first 10 days, if you don't start treating them by the 10th to the second week, they will have severe mental retardation. All the physical features will come back to normal with thyroxine, but not the IQ, and not the cognitive ability. So you have to recognize hypothyroidism as early as possible. Now you know there is island-wide screening for hypothyroidism. And along with that, some other things are also being screened. You would better get updated on that with a more currently knowledgeable person on that. Serious metabolic disorders, one thing, as much as these are needed, they should never be done routinely. You get advertisements in all these big hospitals now saying that such and such, so many for 1,000 diseases, you can screen and all that with a simple blood test. That's a really unethical advertisement and should never be permitted actually, because it is actually seriously harmful to screen for diseases in a baby unless an intervention is available, and that the intervention can prevent harm, because unnecessary diagnosing serious diseases, really um, disrupts the life and really makes the life. In fact, the child may tell the parents, why did you screen and find out this for me? Right? Okay. Like this. So screening should only be done when it is really indicated, right? Not routinely, just because it is available, not because you can afford it. So as a GP, you have to know these concepts, that screening has good sides about it and bad sides about it, and that you don't screen for disease. There are criteria where general screening is indicated. That's criteria. There are laid down criteria when screening is indicated, and you must be familiar with these criteria and not just refer people for screening. Just sometimes parents are curious. You must seriously discuss with them whether it is worth screening. So very often when there is a family history of certain disorders, then you have to seriously discuss, you have to look at the family tree by really plotting how many, and then really decide whether it is necessary to screen or not. Don't do it routinely. So these are the minor problems which you have to be very familiar with. Umbilical sepsis is very common, and you must know how to treat it. Right? Okay. Very often these things. So umbilical sepsis, before it gets systematized or septic, can be treated even with an oral antibiotic. You have to always cover staph plus E. coli. But sometimes just the local management early would be sufficient. Then umbilical hernia is a common abnormality. When there is umbilical hernia, your main obligation is to look for other abnormalities, especially features of hypothyroidism. And it's a condition which needs no intervention, especially in the neonatal period or early infancy. You have to only follow them up and tell them of the very rare possibility of obstruction or strangulation, which is extremely rare, I must say. I have hardly ever seen one. And that is how you manage. Then vaginal bleeding is is to the withdrawal feature in many ways, not a serious thing. Of course, if it is profuse, you have to always consider vitamin K deficiency or this, but it's extremely rare. Minor vaginal bleeding is to be reassured and just followed up. Then the so-called mastitis, where there is swelling of the again, a sign of estrogen withdrawal. Now, most grandmothers make it worse by trying to squeeze milk out of it, and then there is infection. But otherwise, it needs no treatment, just reassurance. Then pustules, of course, can be serious. They have to be treated. So you need to give an oral antibiotics if there are pyrite, cover the staph as a disease E. coli. So you have to see pustules. So sometimes there are some units in which almost every baby who is born there gets pustules within a week or two because of this thing, within the first week. So pustules are definitely a bacterial infection and needs treatment, otherwise could lead to this thing. There are so many rashes that can occur in the newborn period, which are most of the time absolutely benign, not serious. So you have to know about these rashes. I won't talk about them in detail. You can look at pictures and things in Paris, and I'm sure you'll get the dermatology lecture also. You have to know that. Then this another very common condition is nasolacrimal duct obstruction, where there is excessive discharge from one eye. Now, this also can be managed conservatively. All that needs is a little bit of massage of the medial thing on the eye, and then it clears up. And unless there is conjunctivitis, you don't need antibacterial eye drops into the eye, right? You have to just follow up. If it is persistent, of course, you might have to get the eye ophthalmological opinion, which is very rare, I must say. Right? Colic is another condition which occurs in early infancy. Still, we do not know the exact cause of this. Again, it's not a serious condition, but it can cause a lot of problem to the mother Very often, it is commoner when you introduce formula feeding. But if formula feeding is not there, sometimes it can be formula feed milk going through the mother. When the mother is consumed a lot of cow's milk, then you can get cow's milk protein allergy by proxy. So these are conditions. Otherwise, simple. Of course, there is a drug now called simeticone. I think you are probably familiar with that, which is given for colic. Other than that, it's you have to just recognize. Of course, serious intestinal problems like an intestinal obstruction can also start with abdominal pain, but then it will be persistent and not just transient like in colic. Uh, okay, I'm going fairly fast because I want to do these two sections. I like to pause here now. First of all, was I audible to all of you, and was it clear? Can someone answer?
Yeah, it's fine.
Yes,
All
sir,
right.
can.
Right. So, are there any questions that arise from anything I have told you up to now? Anything, I mean, from your present knowledge, anything which doesn't ring true or where you want to seek clarification? Anything? Don't be frightened to ask if you have any doubt. No? Okay. So, we'll proceed then.
Sir, sorry,
Yeah.
sir, can you explain more about vaginal bleeding in
Yeah,
newborn?
vaginal bleeding. Yeah, there is a little, you get a little bit of blood-stained discharge. I think a mucoid discharge in girl. These due to a estrogen withdrawal from mother, and it's very transient, and it's something to be reassured about, right? Nothing to worry. But if it is due to hemorrhagic disease, the newborn, then it is much more profuse and you get other bleeding, right? Okay. So you can just a little bit of blood tinge mucoid discharge vaginally is quite not uncommon in babies. And in fact, those babies can also have that breast swelling also, right? So it's a fairly common thing. Are the others now? I'm glad you asked me that question. Are the others familiar with this, or you have never heard of this before? No one is answering. Okay,
No,
that's
it's
all right.
familiar. It's
Yeah,
familiar.
yeah. It's one of the common things where it can cause alarm to the mother. So it increases your stature as a GP when you know about it and when you can reassure. But of course, you must not falsely reassure. If the bleeding is profuse, better make sure you have to check. Of course, vitamin, K, the hemorrhagic disease of the newborn is not seen in Sri Lanka because all babies get vitamin K. So those days when we were training, vitamin K was not being given universally. And we used to actually see hemorrhagic disease of the newborn. So that is a very, very serious life-threatening condition where you can bleed from various sides. So you have to be able to distinguish that. But nowadays, the chance of you seeing hemorrhagic disease of the newborn is very rare because all the babies have got. Of course, you have to check. You have to ask the mother. Vitamin K දුන්නද කියලා. And now the child health development record, which I'm going to talk about now, will give all this information. So that is the next point I want to, all the, especially this care during infancy and even in the neonatal period, one instrument or this thing tool that will help you is the CHDR. So you must be absolutely, completely conversant with the CHDR and what it contains. All the information. You must know what is the information that is there in the CHDR. You must know all the charts. You must know how to interpret the charts. Then all the infant feeding guidelines, the IYCF guidelines are there in the yellow pages of the CHDR. Now, I hope I'm not out of date in this. Whether the new, I mean, in the CHDRs that I am familiar with, which comes like a book, uh, all these are there. And you have to be, if you do not know what the CHDR is and you do not know how to use the CHDR in your practice, you are not a good general practitioner. So you must, and don't think the CHDR belongs to the state sector. Not at all. Anybody who is providing care to the child is entitled to use the CHDR, entitled to plot weights on the CHDR, provided you know how to do it correctly. Don't do it wrongly. If you know how to plot, you are entitled to plot on that chart and to interpret the chart. So please be familiar with the CHDR, right? Okay. So now coming to the main points during
Excuse
infant.
me.
Yes,
Excuse me.
yes.
So regarding vaginal bleeding, if the baby comes into the practice, what is the indication to admit the hospital and how to
No, no,
differentiate from a
no, no,
hemorrhagic
no, no.
disease of
No, it is not an indication.
newborns?
It is not an,
No.
I mean, if the way you say vaginal, if there is bleeding, if there frank bleeding from the vagina, which is
Yeah.
extreme, I have never seen it. What I am talking about is a slight tinging of blood in the mucus of the vaginal discharge in a
Yes,
newborn.
sir.
If you see that, not at all an indication to admit to the hospital. It
Okay,
is an
sir.
indication. If you are a confident GP, it is an indication. Any symptom that is unusual, you have to review if it persists or if it becomes worse. So that is a golden rule for a GP. So you know what you have to say is, if this gets more, if it is more, please see me again. And the interval at which you see, you can reduce. It can be if you saw it in the morning. I'm not telling for vagina. It's certain things like colic. If you saw it in the morning clinic, you can say I will review the child in the evening clinic. Like that. But say things like vaginal bleeding, you can say if it persists for another day or two, come and see me again, like that. You have to always give them a safety valve, but certainly for a confident GP, it's not an indication to admit, right? Right. It's this. All right. So coming back to
Dear sir,
yeah,
one other question.
yeah,
Uh,
sure.
yeah, with regard to the colic and giving some probiotics, is there
Well,
any proven value?
it's a good question. I mean, generally, I'm against giving medications during the first 6 months. So, simicicone is known to have some effect. Now, probiotics and things, I mean, basically, when you start giving drugs during the first 6 months, you tend to break the exclusive breastfeeding. At the moment, probiotics are not proven to be effective as far as I know. You can check it in the Cochrane database. Of course, the promoters of probiotics claim this, and they'll give you some fancy brochures and all that. But you check in the Cochrane database, go and put the question that if you want to know about proven clinical trials, the place to go is the Cochrane database. Now these are things you must learn, and you put the question: are probiotics effective in the management of infantile colic? Put that question. I have put it some time ago, it was not, but I haven't put it recently. And so you can check that. Basically, I am against giving unnecessary medications during the first 6 months of life. Of course, the exceptions are like in preterm babies and other babies at risk of anemia, you start iron. Even that is usually after about 4 to 6 weeks or so. Very preterm babies, the hospital will determine, and they will say give these things from now onwards. Hospital will recommend if any vitamin and other supplements need to be given to very preterm babies. Otherwise, try to avoid medications in the first 6 months unless they are really indicated. So actually my answer about the probiotics is, to my knowledge, it is not of proven efficacy. I may be wrong. You can check that with other good pediatricians or through the Cochrane database. You can ask the question, right? Okay. Any other questions?
Thank you.
Excuse me.
Thank you, sir.
I'm Dr. Kasood.
Yes. Yes, Dr.
My question is, we often see mothers with fever phobia, and they go doctor shopping and doing various investigation for newborns. what is your experience and the advice for us to
No.
handle the mother?
So I told you in the newborn period, fever is a very serious symptom. You cannot reassure. So if a child, that is an indication for hospital admission. If a child has definitely got fever, he has got definitely, you have to prove it. It's not due to wrapping too much or false measurement or wrong temperature, something like. If he really has fever, significant fever, especially if he has anything like slight, if he has jaundice, so jaundice of course can be physiological, and especially if he has even the slightest of lethargy, if the mother says is less active, and if he has refusal of feeds, even one feed, if he has refused, I mean, that is an absolute indication for admission. That's an absolute indication for admission, because neonatal sepsis cannot be managed as an outpatient. So fever in the newborn period, yes. Now fever in older children where with viral infections. Now of course, even in older children, because of dengue and even chikungunya, doing a full blood count, at least by the definitely beyond the third day or earlier, is probably a good thing. Now, whether doing dengue antigen is really indicated or not, it's controversial. Dr. Lakuma Fernando, of course, insists that it's a good thing, at least to exclude it. But the only thing is, you cannot be complacent by doing dengue antigen, because dengue antigen can be negative if you do it. I mean, if you do it exactly at the 23rd hour, there is a 99% specificity. But if you do it anything after that, dengue antigen being negative does not exclude dengue. So I think the much better investigation is the full blood count. Because from the full blood count, you can very often suspect dengue, because you get a low white count. I mean, before everybody looks at the platelet count, but what is much more important is the total white count starts going down, and then you get the platelets starting to go down. So, so I think the question was the mothers, doctor shopping, and going for people who investigate and all that for every child with fever. I think in infancy, fever has to be taken a little bit seriously. So mothers are right in a way, but when you say seriously, is a proper assessment. The fever, what are the other symptoms, and assessment of the child. Fever and lethargy. If the child is lethargic, if is inactive compared to, if the mother says වෙනදා වගේ නෙමෙයි ඔහේ නිකන් දාලා ඉන්නවා, that is a very serious complaint, right? Okay. So fever and lethargy. Actually, irritability is less. Even with meningitis, what you get is lethargy, not irritability. Irritability comes when they have a painful condition, like osteitis or whatever it is, right? Or an otitis media or something. So as long as you are a competent GP and you do a thorough examination of the child, you find the child is alert, especially in the early period, you can even do a Moro. Absence of a Moro is a sign of illness. So like that, and that the tone is normal and the child seems quite okay, good cry, not lethargic, then you can just watch. So of course, antipyretics are indicated in fever even in infancy, but certainly not antibiotics. Blind antibiotics is the worst thing you can do. You must never give antibiotics to a child in infancy unless you have a specific diagnosis. The diagnosis can be clinical, so like in the case of pustules, like that can be clinical in the case of a cellulitis. Diagnosis can be clinical in the case of a tonsillitis, which is a little rare in infancy. Diagnosis can be clinical in the case of an otitis media. But most of the septicemia, the diagnosis is not merely clinical. And there are two good screening tests now. So you can, I think now most, I mean, the C-reactive protein and the full blood count are good screening tests. Because if there is bacterial sepsis, you will get an increased full blood count with a shift to the left. And C-reactive protein will go up. If both are normal and the child looks clinically well, you can afford to manage him with antipyretics only and reassurance, but review. Review is the most important. Review. I mean, in fact, in an infant with fever, even if you decide to review daily, I think that is okay, right? So you don't have to admit every infant with fever.
Excuse me. So actually, that's not my question, sir.
Yeah,
Uh,
what the question then? Yeah.
My question, sir, the mothers are actually the things like CRP, full blood count, and sepsis. They also well aware, sir, these days actually, not like old days.
Yeah,
They
I
are
know.
very much aware, and
Yeah,
they go Google and see the things, and they keep
yeah.
two thermometers and checking the fever whole
So
day.
what is your question?
Fever phobia, sir, or thermophobia.
No,
With
well, I
people.
know, I don't think there is, I don't know what you mean by fever phobia. Fever is a significant symptom of illness, ne? So, especially in an infant, fever is a significant feature of an illness. So, there is either the commonest cause is a viral infection. So, therefore, you can just manage with antipyretics and constant review. But it is quite right for a mother to be scared of fever, especially if the fever is high. So don't try to make diagnosis on the mother when the child has fever, right? And if the mother is worried, you must have the competence to reassure the mother based on it. You have to say, okay, the child has got fever, but he is clinically otherwise quite well. I have examined and the ears are normal, the throat is normal, there is no infection in the skin, and he looks well and he's feeding well. So we can afford to watch. But of course, I think the threshold for doing, especially if the mother is anxious, the threshold for doing a CRP and a full blood count can be lowered. So that is for reassurance. Okay, if you are worried, let's do a blood test and see whether it is a serious infection or not. That is okay. So I can't give you an absolute indication, but don't start I don't know of a diagnosis called thermophobia. I think that is, I don't know of such a diagnosis. I don't know whether this is, the fever is a significant symptom in childhood. So it is right for the mothers to get, and what you are telling is quite right, especially in intelligent and educated mothers now Google. I mean, we might become redundant in some days in the future if we don't preserve the things that we can offer more than AI or the Google, which is the compassion and the empathy and the ability to relate to people and to give them confidence. So that is one of the things that you have to develop as a GP. So each mother must be treated differently. I don't think there's any place for you to blame a mother or to discard her as saying, "Are you a real idiot?" I mean, she's Google, she thinks she's smarter than me and all. That is absolutely unacceptable attitude, right? So what she says, you have to carefully listen to and then give a rational answer to what she says. I mean, even if you give a rational answer, there are people who will reject and go to someone else that you can't help, but they are a minority. I think most people, if they know, I mean, when they get scared is because most of the time the consultations now, both for specialists and even GPs, are 2-minute consultations or 3-minute consultations. I mean, I must say, I have heard even to top physicians. I mean, I have heard a professor who got COVID and died, and I mean, the daughter said that did not even put the stethoscope on the chest or like this thing, right? Okay. So, so if you are sure that you are making a correct clinical assessment, you can be emphatic, and you can actually make them your partner, the more intelligent mother, and really discuss, as okay, what is it that you are worried about? What is the condition? Are you worried about meningitis? Like that you can ask, and you can show here. I mean, of course, bulging frontal is a late sign, but you can tell them, of course, and meningism doesn't occur in infancy, or not elicitable in infancy. But I think it's a way of you are talking and handling the mother. I don't accept the diagnosis of thermophobia in the mother. I hope that answers your question, but you can double check it with others, right?
So
Okay,
sorry,
sir. Thank you.
sorry for disturbing, sir. Sir, so
Yeah.
if there is a patient, if there is a baby less than 1 month in the neonatal period,
Yeah.
if patient is brought with 1 day history of fever, think about it's about 100 Fahrenheit. Do we have to investigate with full blood count and CRP? Another question is after 1 month to 6 months, if there is a child with fever for 1 day, do we have to investigate further and whether we can see the patient with measuring blood pressure, temperature?
Well, no. Take the two questions. Neonatal period, if you confirm that the child is really febrile, more than 100, I think the admission is the best course of action. The child needs to be closely watched. The mother may not be this thing. So in the neonatal period, said if you have access to a CRP and a full blood count which is reliable, which you can get immediately, then so like in a upper middle class kind of setup, you might do that. And if that is normal, you can afford to watch for a day, but that is about it. The second day you will have to admit, even if the CRP was normal, if the child is febrile and has even the slightest sign, any other sign of illness. I'm talking about that is a newborn to 1 month. After 1 month, no. If after 1 month, if the child is quite well, you don't even have to do a CRP and full blood count the first day. But certainly with dengue going around, you definitely have to do a full blood count by the third day. So the day that you do the full blood count and the CRP, it is flexible, depending on the mother's anxiety, depending on your uncertainty as to whether it is viral or bacterial. For example, if there is a runny nose and a cough and the child is having fever, you have got a diagnosis. It's a viral upper respiratory tract infection. And if the child is generally well, you can reassure the mother this is a viral upper respiratory infection. You don't have to do that. But if the child doesn't have any symptoms and is just having fever, that's a little bit more concerning because till you find out. So it is difficult to give an answer which fits every. Each patient has to be assessed well. So my main message is, if you are taking a good history and doing a thorough clinical assessment of the baby, right? And you think the child is well, you can treat it like a viral infection. If you have the slightest suspicion, investigate. If you think the child is ill looking, definitely better to admit to hospital because in most of these cases in infancy, they will require intravenous antibiotics and not oral antibiotics. Right? Okay. Shall we get on from there now? Are still any doubts or any clarifications by any of the others? The person who asked me the question, are you happy or you want to ask me anything more?
Yes, yes, sir.
Okay. All right. So I think my main thing is that fever is not to be taken lightly, but it should not also be just taken as an indication to immediately admit. If you are a competent GP, you can make the assessment yourself, especially in the post-neonatal period. In the neonatal period, my threshold for admission will be very, very low. Right? Okay. Right. Okay. So now coming back to care during infancy. So first thing is IYCF. You must be thoroughly familiar with the infant and young child feeding guidelines, which includes exclusive breastfeeding for 6 months and complementary feeding after 6 months, not in the 6th month, after 6 months, and planning to go to adult diet by very optimistically by 12 months, which is very difficult to achieve, but at least by 18 months to 2 years, the child should be able to take an adult diet. That is what all mammals are supposed to do. All mammals have an initial period of exclusive mother's milk, and then they get used to the adult food. Depending on the species, the time period varies. Unfortunately, in humans, it was not known, and we used to give solids by 2 months those days. Now we know definitely it is not indicated till 6 months is completed. And of course, it is the other factors, and if the weight gain is poor and if there are other illnesses, your management may change. So be thorough with the IYCF guidelines, which I told you are found in the CHDR. Immunization schedule, again, I must say, be absolutely thorough with the current immunization schedule and the extremely rare contraindications to it. And make sure that the child and the mother complies with that immunization schedule. It's in the CHDR, and we know now that there is a small percentage of people who are becoming vaccine skeptics, or not skeptics, they refuse vaccines. So that is due to, I'm told, due to some religious reasons. Then we can't force them. We don't have the right to force them because vaccination is not compulsory by law in our country. Very few countries have that like that. So we can't. But only thing is, you must be aware. And if you have in your practice such people who have refused to take the infant immunization, you must really mark them as high risk patients, and maybe you must even alert the MOH about them, because those are the people in whom relapses of various diseases like measles and all can recommence, right? So please follow the immunization schedule and implement it correctly, and motivate mothers. Now, doubt regarding the adult immunizations like COVID and other things, there are pros and cons. There are certainly serious side effects that can follow from those immunizations. And also there are some doubts regarding the efficacy. So it's a balance of things. I'm not saying I'm not, yeah, that is a different argument, right? That's a different argument, and you have to discuss the pros and cons differently. But for the infant immunizations or the immunizations in the CHDR, the evidence is overwhelming that they give more protection than the risk of side effects is very, very small. Nothing is nil. There is always, with the especially the uh, whole cell pertussis vaccine, which is part of now pentavalent, there is a certain risk of getting fits and even sometimes infection, but the risk is very small. And it's a risk that you would take for your children, and therefore you should be prepared to recommend it for other children. If you are not prepared to take it for your children, then you have a bit of a problem in your conscience trying to force it to other children, right? Okay. So that is the rule by which I play. So immunization, you have to be very. Next, coming to developmental assessment.
So
This is,
excuse me, sir.
yeah.
Sir, there's a small doubt for me, sir. Sir,
Yeah.
now in the there's a EPI schedule, there's this pentavalent vaccine. In the private sector, there's this hexavalent vaccine. And now, if we are giving, if there are babies who like been given hexavalent, so if they have been given this hexavalent, do they have to get the OP, oral polio
I
dose,
can't
sir?
tell you. I can't tell you the details of that. I know I'm in the advisory. There is slight modification, so that you should verify. Now between pentavalent, hexavalent is not wholesale. It is the more expensive vaccine, and that is of course slightly safer vaccine. So if the parents can afford and they want to take hexavalent, you must not discourage them, right? Because that is
Okay.
definitely the risk of getting side effects is less than with the wholesale preparation. But in general, I mean, my relatives and my children have had the wholesale uh, pertussis vaccine, right? But if you want to, I mean, you have to be honest, no. If you
Yeah,
take
yeah.
hexavalent, there is a slightly lesser risk, right? So if they can afford, they can take the hexavalent. If they take the hexavalent, how you modify the polio vaccine schedule, I don't know the details. I know it has to be modified because everybody has to get IM polio at some stage. So you have to check that with someone from the epid unit or whatever it is, right? Okay.
Okay, sir.
Can't answer you that, right?
Okay.
That's a good question.
Okay, sir.
And developmental assessment, you must be familiar with this. Mind you, most babies now, they will also be going to their local child welfare clinics. For God's sake, don't discourage them from going if you are the GP, right? I mean, I know Professor Leela Karunaratne, who was the first professor of family medicine and general practice. She used to do a thorough practice where she did all the things, including the growth monitoring, the development assessments herself, and the immunizations and everything. But you don't have to take on the whole responsibility. If they can get it free through the government and that the services complement you, then you must allow them to do that. So, but still you must be also aware, because I must say I am surprised to see that there are children with developmental delays in certain aspects who have been completely ignored, especially speech delay and things like that, by the GPs and even by the CDAP child welfare clinic. So developmental assessment you have to be familiar with. There are locally developed developmental standards now that also you must be familiar with, right? Okay. And vision and hearing, I have already talked about. Those days we used to check for hearing only at 6 months. Now I think they are screening for it before. You must know how to check clinically for hearing, right? The distraction test you must know. Then growth monitoring is absolutely important. So CHDR belongs to everybody who provides care to children. Everybody should definitely look at the CHDR and the charts, and you should not hesitate to plot on the CHDR and the charts as uh, as long as you know exactly how to plot, and as long as the measurements you are plotting are reliable. They are not on a bathroom scale or something like that, right? Okay. If you have a proper measuring equipment for children and you are sure that the weight that you are recording or the height you are recording is accurate, you are allowed to plot on that and then to interpret the line. So growth monitoring you have to be involved in. You have to look at the charts and know how to interpret and know when to refer uh, for specialist attention. Then the psychological aspects of childcare, especially the need for bonding, not only with the mother, bonding with the father, bonding with the other members of the family, and the need for providing stimulation to the child. That is not necessarily with expensive toys, but whatever is there from the environment, teaching them colors, showing them colored birds, showing them flowers. This is important. Now, I hope you are aware there is a category of graduates called health promotion graduates. It's a 4-year degree, and these health promotion graduates are also in. Few of them are in the health ministry. There is no post for them in the health ministry, but they are working through various NGOs and other things, and they are doing an excellent job, especially in helping mothers to bond and stimulate their children as a part of childcare. So so all of you know about this critical thing called the 1,000 days, early childhood development, that the critical period where all your personality, your adult health, your stature, your growth, whatever, all that is determined to a great extent by what happens to you during the first 1,000 days. First 1,000 days commence from the point of conception, 9 months, and the 2 years after that. So those first 1,000 days are critical. And what happens to the child during that period is very important, determining his whole life course. So you have to know about that and make sure that they get the right background or whatever it is during the first 1,000 days. Uh, I think, and then general care means bathing, clothing, and things like that. I'm not going to go into details of this, but you must know through common sense For example, when you see children being brought to a surgery in florid nylon, I mean, all kinds of unhealthy dressers and things like overdressed and things like that, you have to, of course, don't be rude to them. Nicely talk to them about the need for comfort being more important than style and things like that, about bathing and things like that. I can't give the details, but as a general practitioner, you must be familiar how to advise them on all the aspects of general care, including dental and things like that, right? Brushing teeth and all. I always ask the children under 5, when they come after my consultation, as they leave, like that. I made it a habit just to impress on the fact that brushing teeth is a very important thing. Right. I think if we want to do the case history, we'll have to go a little bit further now. What's the time now? Yeah. Now it is, what's the time? 10. Okay. I should have finished the lecture by now for the case history, but that's okay. I think I enjoyed the interaction so far. Let's continue. So I told you that we have early child development standards. These are Neil Talagala was the key work on this. These are you can get these. These are published, right? Okay, these are the local childhood standards. Then growth monitoring, how to measure length. Up to 2 years, you have to measure length and not height. And then after 2 years only you measure the height. Then how to check weight, how to measure OFC, you must be familiar with this. How to plot them and to interpret the charts, you must be familiar. These the child development chart, the blue for the boys and pink for the girls that I am familiar with. Right. Okay, let's go. So that's the first year I told you the what are the important things. So now after the first year, we call them toddlers, the ones who toddle around. So that these are also very important period. They are during the toddler period, 1 to 3 years. So what are the important aspects? Do you want me to hold for a second? Any questions or any clarifications on what I said earlier? No. So growth monitoring continues. Okay, growth monitoring continues. Developmental assessment continues. You must be familiar with the development milestones, right? When can they climb stairs? When can they do a tricycle? Whatever it is. When can they draw a line or whatever it is? You must know those things. Bonding and stimulation, very, very important during this period. The need to stimulate a child. You don't need Fisher Price toys for this. You can stimulate them with the pure environment, showing. I mean, one of these health promoters told me that one of the mothers was stimulating the child by showing there was a pear tree in the thing, and it had the first gediya, first the fruit was there, and the mother was showing this child uh, how the pear Gedier becomes bigger and the color changes. And then one day that was attacked by worms. But she used that even to show the worm and to show the child and to stimulate the curiosity. So there are so many things in the environment, and even in the urban environment, there are things which you can use to stimulate children. You must be familiar with this concept, the need for stimulation, mental stimulation of the child, and bonding. Then continuing the immunization. You must know the schedule thoroughly and continuing the immunization. So during this period, of course, the febrile child is the most important thing. We have already talked a lot about it. The febrile child is the commonest thing that you will see in practice. Then, of course, the commonest infections you will see in your practice are respiratory tract infections. Large majority will be URTIs, upper respiratory, and large majority of the URTIs will be viral. But few can be bacterial, like tonsillitis or pyogenic otitis media, and diarrhea, fortunately, is now rare. I must say it's becoming a little bit common again. I don't know why. Because our sanitation has gone up, and also all the mothers are not now fully familiar with ORT, oral rehydration. You must be completely familiar with oral rehydration. oral rehydration therapy, the packets, how to reconstitute everything. The mothers will probably know more than you if you don't really read about this and be familiar. You must know how to. I must say, majority of the GPs, even when they are managing diarrhea, I must correct that. Say, quite a significant number of the GPs are not talking about ORT, right? They are using antibiotics and various things, and they're not talking about ORT, which is disappointing. It might be different. I'm talking about 6-7 years earlier. Now, the really, really important new aspect that comes in at this stage is called child protection. Two aspects to child protection. One is prevention of child abuse. Second is prevention of home accidents. Both are really, really important. I don't have time to go into this in detail. I'm sure you'll get a lecture on this. And there is a beautiful book about child abuse, edited by Prof Aswini and people like that. Prof Harendra and all involved. I think you can download it. It's available online. I can't remember the exact name. You must be thoroughly familiar with that book, because that tells you how to suspect child abuse, what your role is, what are the case conferences. There are 2 case conferences that are held, initial one to diagnostic one and then the management one. You must know all of this. These are all available in that book. Please refer that book and get it. Then, of course, the other important category of disorders during this period are the behavioral disorders. One is, in fact, I don't, this is negativism in the sense where, especially when you try to force feed a child or tell a child to do, he does the exact opposite, especially you must be familiar. Then ADHD is quite a common condition and should be diagnosed. You must have a low threshold for diagnosing, but don't cause unnecessary worry. But you must be perceptive to symptoms mentioned by the mother. Then the autistic spectrum is also far commoner than we have thought before, and you know the absolute importance of diagnosing it early. Diagnosing it early and intervening. I must confess, as a pediatrician, I have missed quite a few autistic children in early life. But fortunately, many of them I did pick up eventually, but I should have picked them up long before. I'm talking about long ago. I mean, I was actively doing clinical pediatrics like in the 1980s. So that is you are to the behavioral disorders you must be quite thorough with. I'm sure your course will have lectures and discussions on this. Then, of course, the main pathology you will have to deal with, the serious pathology, is asthma. So I won't go into that. You have to know about the management of asthma, the guidelines, the indications for inhalers, how to monitor the inhalers, how to advise them on inhaler use, how to manage. I mean, everybody, if you are doing a proper general practice, you should have nebulizers in your surgery and things like that. How to manage asthma, you must be there. And then the next thing you will be asked about is daycare, because many mothers going for work, about daycare facilities, how to identify a good daycare arrangement. This also you must be thorough. If you are working in an area, you must know all the daycare facilities in your area. And you must be able to discuss with the mother the pros and cons of different ways of daycare. So this is about 1 to 3 year management. Okay, lots of things are there, but I'm not going into detail. I'm just highlighting and telling these are the areas that you have to be really familiar as a GP. Any questions before I go to the next slide? Any questions?
So regarding mental health,
Yes.
I have seen a lot of parents are not accept the child mental health.
Absolutely
That's
correct.
the
You are
main problem because
absolutely correct. You are absolutely correct. I know one of my close relatives. One of my close relatives, up to now, she and her parents don't accept the diagnosis and it has caused immense harm to that child. This is a major problem which you will not be able to tackle by yourself as a GP. You will have to definitely get a pediatrician and a child psychiatrist involved in this. I agree, it's a major problem. 1 minute, I'll just. Hello. Anilata, I'm in the middle of a lecture. Can you talk to me later? Right? Okay. That's all right. Okay. Yeah. I fully accept. I think refusal to accept the diagnosis of autism is a major problem and it has to be handled extremely carefully. You have to use a pediatrician and of course someone who has time to this and a psychiatrist and also any either counselor or sometimes you might choose if you are treating the extended family you have to use members of the extended family in trying to influence them. It's an area where I can talk a lot about, but there is no time for it. I fully agree. The refusal to accept the diagnosis, right? Okay. All right.
Dear
Any other?
sir, with regard to IYCF and stimulation,
Yes.
what is your opinion with regard to the feeding table and keeping the child inside?
No, say it again. Feeding tape.
Yeah,
No, feeding.
feeding chair, and
No,
yeah.
feeding chai is absolutely critical for children with motor disabilities and all with cerebral palsy and all is absolutely critical. I don't think it is an absolute necessity for all normal infants, but I am not against it, right? Okay. I think there are different ways. Some mothers feed the child on the lap, or some mothers feed the child while the child is using. So feeding chai not essential for normal children, but feeding chai is absolutely necessary for children with cerebral palsy for their feeding, right? Okay. What is the other question?
With
But
regard to the stimulation, sir, showing the environment and things, the feeding table and feeding chair, will it affect, sir? That is the question.
I'm not sure what do you mean by the feeding table and feeding chai. I'm not sure. I think I'm not quite sure of what you are referring to.
Because all of my children have brought up with regard to the exposure to the environment.
Yes.
Some families practice that they should keep the child on a feeding table and feed. Uh, I suppose the
No.
stimulation
I
factor,
think these
yeah.
are individual. It is like individual things. I'm not such a in favor of this feeding table business, right? Okay. But I will not force my opinion on the parents. I will just listen to what they are doing, and if it sounds okay, if it sounds as if they're trying to fit the child into some kind of rigid behavior during early childhood, that's not a good thing. Then you have to gently discourage them from doing that. But certainly, looking at the environment and using it to stimulate the child is something you can talk about. Which means, even without toys or whatever it is, you can really stimulate children just by looking at the sky, looking at trees, looking at birds, looking at butterflies, or looking at flies and mosquitoes, even, right? Or spiders. The recognition of danger is a very important thing in a child. Not to put your finger into a plug point, things like that. Those are the things in the third year, in child protection. I didn't go into details. So you have to, there are some children who are quite reckless, their behavior. They want to, they try to do things. Because you see, it's a part of the personality. You know that there are people who are called thrill seekers. The ones who do bungee jumping and things like that. So even from childhood, those tendencies are there, and sometimes they can be quite dangerous. So it is difficult to specify, but if you are a good general practitioner, you are aware of all these. Main thing is to listen to the mother and see if it sounds sensible, go ahead with that. Only if you think it's really harmful that any practice they are doing, you should try to discourage. That's my advice to you. Right? Okay.
Thank you,
All right.
sir.
Shall we go to the next slide? I think the management of children with special needs. Now, these also manual for primary healthcare workers. These are all these not merely cerebral palsy. These with all the children with special needs. It's a book really worth. I mean, there might be updated version of this, may be available. It's a book really worth for you to be familiar with. Then this is a very old version. Okay, so don't go by this. There is a much better book on child abuse now available, right? Okay. Preschool period, choosing a preschool or a daycare. I think the parents might involve you in this, and you must be confident of this. Please don't send them to preschools which have convocations and sports meets and all where medals are given and all that. So many are like that. You know, the preschools which just allow the child to play and interact are the good ones, not the ones that teach the child Sanskrit and geography and all that, right? Okay. So there are so you must be intelligent in choosing, advising mothers about daycare and this thing. You must be familiar with what is available. Of course, don't uh, be noted for criticizing any particular preschool. Do it in a. You must know what is good. Many of some of the preschools are absolutely. I mean, they are like university. There are preschools which have convocations, right? Okay, so I think the mothers should be made to avoid them, right? So you must know how to select a preschool or a daycare to continue the immunization even during the preschool period, continue the growth and developmental assessment, child protection continued, bonding and simulation continued. Now the new one here is this: socializing, developing the personality and toilet training. Socializing, social interaction, the importance of social interaction, how they interact, how to provide the child opportunities for social interaction, especially, I mean, many single child families are there now. So this is very important. So you have to be able to talk to parents about the importance of this. No rigid toilet training, but you have to have some guidelines as to various methods of developing the right habits. Then, of course, I have put this what is called the joy of parenthood. First thing is, don't exclude the father. Don't exclude the father. Your interaction should not be solely with the mother. You must insist on the father coming for at least some consultation, especially when you are talking about general child care. So, and they should be, I mean, one of the most beautiful things of life is being parents. And so, as a doctor, we have to help the parents to enjoy their parenthood and to make it healthy for the child and happy for the child and the parents. So that's the message. I think that is the last slide. Any questions? Now, I think we have time. How much? 10:20. Yeah.
Sir, sir, I have a problem. I have a question, sir, regarding preschools.
Yes.
In our society, there are families. They are talking with children in local languages, and there are some families uh, in with children they are talking international language. What's your view regarding children from local language families sending children to preschools where international language is used?
Yeah,
I
you're talking
think that
English. Yeah, okay, all right. No, it's like this. What is very clearly shown is that what is best for personality development and even for educational success is that in the primary stages of education, the mother tongue being used as the medium of education. But that does not mean that you cannot teach another language. Young children can learn not one language, even three languages. They are very good at picking up languages. But talking about now, so then about uh, using the mother tongue for primary education. So actually, I think one of the serious mistakes that past governments did allowing this so-called international schools even at primary level for local children. During my time, the international schools were meant for overseas diplomats, etc. Then now in every street corner, you get internationals. They are teaching in English and things like that. So, and it's a fashion. So they want to teach. I think it's especially if the language that is spoken in the home is Sinhalese. And to teach the education being in English is not a good thing. But there are many upper class families now where the first language for them is English. So that's a different thing. That's a different thing. In which case, of course, starting off in English is okay. If you are I personally wouldn't like it. I mean, although I speak English, even my granddaughter now who's living abroad, we insist on talking in Sinhalese when she comes home. Right? Okay, and she can now speak quite well Sinhalese, although she's been living all her life abroad. I like that. So it's a yeah. I think primary education is best in the mother tongue, not in English. So about sending to preschools which use only English is a highly personal decision. If the first language for you in the home is English, then there is no problem. But if the first language in the home, especially with the others, relatives or whatever it is in Sinhalese and the language is in English, but teaching English to young children is quite okay. Teaching, I'm not talking about preschool children, but primary school children. I'm fully for starting teaching English in the primary school. Right? Okay. I think, all right. Any other questions? I think all the questions you have asked are extremely good questions, and I hope I managed to answer. I told you, I know what my limitations are, so don't take everything I say as truth. You balance it with your existing knowledge, and you can double check with other people who are more knowledgeable in the area.
So regarding the feeding, in the
Yes.
for adult feeding, for they recommend for 20 minutes for each meal, sir. In the
No, don't be too rigid on that. Usually they say 20 minutes at each breast. I think there are some children who are quite skilled at emptying the breast within 10 minutes or so. So I don't go rigidly for 20 minutes at each breast. I think the person who you can sort out things on breastfeeding, who is really expert, both as a mother and a pediatrician, in Nishani Lucas. You can double check with, she's a professor, I think now, Nishani. She was my registrar. Nishani will be able to tell you. I don't think you have to be very rigid in this timing of the breastfeeding.
okay, sir. Thank you. Other question is me for what about the influenza vaccine for annual influenza vaccine for the children with having the asthma?
No, that I don't know, man. I don't know. I have not used it. I I must confess that even as an adult, I have not taken influenza vaccine myself, which is probably wrong. So I don't know if they say that is a good thing to take, and the organisms that cause influenza in Sri Lanka are the ones that are covered by the influenza vaccine, I suppose. But all you see, I'm not. I think the vaccines that are in the EPI have been thoroughly discussed before being introduced. We recently had the vaccine summit, and thoroughly, there has been a consensus that they are safe and good to this. Anything that is not in the schedule, I think is a personal thing, but you have to discuss with some specialists. So I'm not sure about routine influenza vaccine for asthmatic patients. I'm not sure about that.
Sorry, sir. Another one question for the sir. What is the cutoff hemoglobin value for the term and preterm for the start the hematinic, sir?
No, I can't tell that to you offhand. Cut off HB value for anemia, no?
Yes, sir. For
Yeah, please check that from a reliable source. I can't tell you offhand from my mind now.
okay, okay. Thank
I
you.
think it's lower than, it's much lower, but you need to check you can get that really. You can
Okay.
even Google that and get it, right?
Okay.
All right. Yeah, okay. Right. So we'll go to the next one. I hope there is time for it. Uh, Wait. Ah, here it is. Okay, let's go through this quickly. This I actually prepared when SLMA started during the COVID time, I think. So it's fairly old, 2019, when they started what are called Zoom sessions for mainly medical students and young trainees. And people were asked to develop case discussions through which you teach. And I think the average attendance in sessions like this was over 1,000. I think for my one, there was 1,000 or more, this particular one, when I first presented it. So I don't know whether any of you have heard it. So these case discussion I developed about 6 years ago. So again, certain aspects may not be strictly up to date, but let's go through it. Wait, I have to- An 8-month-old baby is admitted to the pediatric ward with a history of watery diarrhea of 2 weeks duration. Bowels open 4 to 5 times a day. The stools are watery with no blood or mucus. The stools come explosively with a lot of gas. At the onset, there had been fever with occasional vomiting, which had settled within 5 days. There is no vomiting or abdominal colic at present. The appetite is reduced and the baby is less active than usual. The baby had been seen by a GP on the second day of the illness, that is the original illness, 14 days, and treated with an antibiotic, cefalexin, paracetamol, domperidone, and ORS. The diarrhea, which improved initially, has worsened during the last 5 days. The urine output is reduced during the last 48 hours. That is the history. This happened to be last time also. All right. The case history continued. On examination, the baby seems moderately wasted with mild reduction in skin turgor. The abdomen is mildly distended, but the bowel sounds are normal. There is flexural eczema in the elbows and severe perianal excoriation of the skin. There are no other significant findings, the other systems being normal. The weight for age curve in the CHDR is shown here. I'm sorry that I don't have the CHDR which I showed now. I can tell you what it showed. It showed the weight flattening coming from the to this thing and coming close to the -3 SD line and dipping during this illness. Weight had gone down during this illness. That is what it showed. So a flattening curve with a sudden dip with the present illness. So question 1, what is the most likely initial illness that this baby had? It's a single best response question. Only one answer is right. So the options are rotavirus gastroenteritis, enterotoxigenic E. coli infection, parenteral diarrhea secondary to a UTI. I hope you are conversant with that concept of parenteral diarrhea. Parenteral diarrhea means, especially in infancy and early childhood, children who have infections in other sites of the body other than the gastrointestinal tract tend to have diarrhea as a symptom. With measles, this can happen. With a UTI, this can happen. Even with a otitis media, this can happen. But it's a transient diarrhea is merely a symptom and there is no infection in the gastrointestinal tract. So that is one of the options. Shigella dysentery infection, giardiasis. So when I used this, it was possible to see the responses from the audience and count, and then, I can't do that. Would somebody want to offer the correct answer here? But we'll go through each one after that. Anybody wants to offer what the correct answer is?
So this is shows that
Don't
long-term
give the
diarrhea.
reason, just give the answer. What is the answer?
Answer C. C.
No. Parenteral diarrhea. Parenteral diarrhea won't last for 14 days. Parenteral diarrhea won't cause. C is parenteral diarrhea. Secondary to UTI, no.
Initial illness was due to rotavirus gastroenteritis.
Yeah, absolutely. That is the correct answer. Initial illness. I told you in the initial illness there was mild fever. There was a little bit of vomiting, no colic, but it was a watery diarrhea with no blood or mucus. But the GP had given cephalexin, that's a different thing. But rotavirus gastroenteritis is the most plausible answer. Enterotoxigenic E. coli also causes a watery diarrhea. So that is a possible answer. In fact, many travelers who get diarrhea in Sri Lanka, some have an enterotoxigenic E. coli infection. But in an infant, at this age, rotavirus is the parenteral diarrhea. When you have fever and a little bit of diarrhea, and then you find that he's having either pustules or he's having otitis media or a urine infection, that's a parenteral diarrhea, very transient. It never causes dehydration. It doesn't cause problems. It lasts for a day. It is just a symptom and it clears off on its own. So parenteral diarrhea never leads to any problems in the child, the diarrhea. So it's not, but it's very common. You have to be aware of that. So just because sometimes what happens is children with meningitis are diagnosed as gastroenteritis because they come with a diarrhea, but that's a parenteral diarrhea. The child is really having meningitis. So that is, of course, rare, but it can happen. Shigella dysentery also, of course, no blood and mucus, you might say you can rule it out. No, you can't. Because in the first 48 hours of Shigella dysentery, the diarrhea can be watery. And the blood and mucus can only appear sometimes in the second day or the third day. So it doesn't rule it out. And giardiasis, especially in developed countries even, giardiasis is one common cause of causing a watery diarrhea at any age. Right? Can cause it. So as you can see in this question, it is a good SBR because all the answers are plausible. But only one is correct. All are plausible. None is an absolutely wrong answer. But one is correct. You have to balance, and the correct answer is definitely rotavirus gastroenteritis. Question 2. Now, this is very relevant to what complications of acute gastroenteritis are present in this baby? Now, this is a true-false type. It's not a single best response. And I'm giving you the answer that there are at least 3 correct answers here. What complications of acute gastroenteritis are present in this baby? Okay, let's go and you can give a collective response. Moderate dehydration, right or wrong? Right, because there
This
is
look
mild, we said no, reduced urine output also. And this thing, so in mild dehydration, there are hardly any symptoms. So there is moderate dehydration in this child. It's got a reduced urine output. And I think we said the skin turgor was also slightly reduced, right? So you don't need a lot of symptoms. So moderate dehydration there. Paralytic ileus. Is paralytic ileus present in this child? It's a well-known complication of acute gastroenteritis, especially in malnourished children. Is there paralytic ileus? What's the answer? No, I said no, vowel sounds are normal. In paralytic ileus, there'll be vowel sounds are absent. But he may be having impending paralytic ileus because there is abdominal distension. Hypokalemia is a common complication of gastroenteritis, and they get, especially if they have protein energy malnutrition, they are basally hypokalemic, and the hypokalemia gets aggravated with the and they can get paralytic ileus. This child may be on the verge of getting paralytic ileus, but he has not got paralytic ileus now. Secondary lactose intolerance. What's your answer?
Yeah.
Secondary lactose intolerance?
True.
Yes.
No.
All.
Come on. Now this is a classic case of secondary lactose intolerance. The stools come out in lactose intolerance. What you get is called osmotic diarrhea. And it is explosive because there is a, you see the undigested sugar comes down and it is broken down by the organisms in the colon, and there is production of lactic acid and gas. So the stool comes out. අම්මලා කියන්නේ හෝස් කාලා එන්නේ බඩේලිය හෝස් කාලා යනවා කියලා කියන්නේ with a lot of gas. That is typical of lactose intolerance. And I told you, this child he had a diarrhea at the beginning, then he got better, then he got this. So and this is typical lactose intolerance. And there is perineal excoriation of skin. No, I told you that. That's a child, that is a classical sign of lactose intolerance, perianal excoriation of skin. And I think I need to go back to the history for you all to. No, I'm going back in the history. Let's see. Bowels open 4 to 5 diameters. Stools are watery with no blood or mucus. The stools come explosively with a lot of gas. At the onset, there had been fever with occasional vomiting, which settled with 5 days. There is no vomiting or abdominal colic at present. The appetite is reduced and maybe less active. The baby seen by the GP on second day of the illness and treated with antibiotic, paracetamol, domperidone, ORS. Diarrhea, which improved initially, worsened during the last 5 days. The urine output is reduced. On examination, moderately wasted with mild reduction. So moderate dehydration is definitely there. The abdomen is mildly distended, but the bowel sounds are normal. There are flexural eczema in the elbows, severe perianal exposition of skin. No other findings. So other than the flattening of the weight curve. So secondary lactose intolerance is definitely in this child. Of course, it can be proved by taking the stool water and doing clinic tests, not clinistics. Clinistics test for glucose. Clinic tests test for reduce, or you can do Benedict solution. So, and it will be strongly positive because secondary lactose intolerance is there in this baby, definitely. Aggravation of acute malnutrition, definitely there. No, I told you, he had been going flat and now there is a dip in the thing. Dermatitis due to zinc deficiency. Now, this is what is called a distractor or a thing. I mean, we told you about the rash and all. In zinc deficiency, you get a rash. But the rash of zinc deficiency is not what we are seeing here. What we are seeing here is the rash of atopic eczema. It's not the rash of zinc. And perianal excoriation is due to lactose intolerance. The zinc deficiency rashes are periorificial and acral. Periorificial, around all the orifices, mouth, nose, anus, the vulva, vagina, like that. Periorificial and acral. Acral means at the tip of fingers, tip of toes. That is the zinc deficiency rash in acrodermatitis empirica. So this is not the zinc deficiency rash. This is two rashes are there, the rash of atopic eczema and the rash of perianal excoriation due to lactose intolerance. Okay. Now this is really relevant to this group. No. Question 3, true false type. Again, many answers. Identify deficiencies in the early management by the GP. Number 1, inappropriate prescription of antibiotic. True or false?
True.
True, absolutely. There was no indication at the beginning. It was a watery diarrhea. I mean, it was probably a viral thing. If there was blood and mucus, at least you can say, but there was no, or if the child was very sick or something like that, but no indication for antibiotics, right? When you're in doubt, do a stool report, and if there are puzzles full in the stool, you can give an antibiotic. But otherwise, if there's blood in the stool, you can give an antibiotic, but not otherwise, right? Inappropriate prescription of an antiemetic, he had given domperidone. Is that true or false? What do you say? No, it's not at all true, because that is the only drug that can be permitted during a gastroenteritis. There is very often a little bit of vomiting in rotavirus and it is okay to symptomatically stop it. Symptomatically stopping vomiting is perfectly justified. So giving an antiemetic is not wrong at all. I mean, if there is absolutely no vomiting and no this thing, I mean, then you may not give it. But prescribing it in this situation when there is a little bit of vomiting or tendency to vomit is quite okay. Not prescribing an anti-diarrhea. He has not given loperamide or whatever it is. So is that correct? Is that the false thing he has done? Come on. Now you all are, they pass the, I mean, this is a real trick. Obviously, antidiarrheals are absolutely contraindicated in pediatric practice. Antidiarrheals have no place in pediatric practice. They are absolutely contraindicated in infective gastroenteritis. They can cause serious problems like toxic megacolon. So the only place for antidiarrheals are with things like irritable bowel syndrome, or when an adult has got a diarrhea and he has got an interview with the boss the next morning or something like that, then you can give loperamide or something like that. But in ordinary gastroenteritis in childhood, there is absolutely no place for antidiarrheals. Those days we used to have things like choline and pectin, which are stool thickener. Those are all useless and harmful because it induces complacency in the mother without the diarrhea getting better. So antidiarrheals are absolutely contraindicated in pediatric practice. Very rarely, if you think it's a pediatric IBS, you might consider it, but that's a pediatrician's decision. Certainly, I don't think in general practice, uh, in in children, antidiarrheals should never be prescribed. Now, the question that was asked from me is here, not prescribing a probiotic. At the time I prepared this question, I checked out with the Cochrane database and things like that. The answer was no, that probiotics are not. I think it may be different now. I think prescribing a probiotic in this child may be all right now, but please check that out. I think it will certainly not do any harm. Prescribe because not prescribing zinc supplements, absolutely correct answer. Zinc supplements are mandatory in every child with gastroenteritis. You have to give it for 2 weeks. You have to give it for 2 weeks and you have to give a certain dose, I think 10 milligrams or whatever it is. That is the WHO has recommended. It's a global recommendation and it has definitely shown to influence the duration of the diarrhea. It has definitely shown to introduce, to prevent the aggravation of malnutrition during diarrhea and complication during diarrhea. So zinc supplements are the, I suppose the only drugs that can be given during a diarrhea are zinc supplements and antiemetic and maybe anti-pyretic if the child is febrile, right? Okay. Any questions based on this answer so far? Any confusion? Any confusion or any disagreement? I like disagreements, because I believe in the Kalama Sutra. You have to only accept what makes sense to you, not what the teacher tells you.
So with regard to antiemetic like ondansetron, below 1 year of age, is it okay?
What is that? What is it?
So ondansetron, like syrup,
Oh, no,
emestat.
ondansetron is definitely a second line drug for me. Domperidone is the first line drug, right? Ondansetron is a extremely effective, and I think the only time ondansetron wave is if you think it is food poisoning and there is severe vomiting. With food poisoning with severe vomiting, ondansetron is okay. I don't know. I mean, other pediatricians may disagree. In my case, still the first line antiemetic would be domperidone. Ondansetron I would reserve for ones which are resistant to domperidone. That is my answer. But you can check that with the currently practicing pediatrician. I think, right? Okay. All right.
So because I asked, there are some strips which are dissolved in the tongue.
Ondansetron, is it?
Yeah, ondansetron.
Yeah, I don't know.
Orally dispersible.
I don't have any experience with this, so maybe it is. I use it as a second line when there is no response to the domperidone. Right? Okay.
Thank you, sir.
Question 4. This is a single best response question. What other history is most important in order to make a complete assessment and plan of management? Now, I gave you a limited history so far. So the question here is, what is the other history that is really important in this child in order to make a complete assessment, clinical assessment, and a plan of management? Who can give me the answer here? All are plausible. All are plausible, but only one is correct. Who wants to give an answer? What? Don't be scared. I mean, you can make a mistake. There's no problem. Can someone offer something? What do they think? Okay, let me go through it. Now, social. Yeah. Who is the lady who spoke? Who is the lady who spoke?
Me,
What's your name?
DLM Vikram Singh.
And what's your choice? Dietary history, is it?
Yeah.
Yeah, you're absolutely correct. Dietary history is mandatory. No, social history is very desirable. If you are a good GP, you must always take a little bit of social history. So in that sense, it is mandatory. But in this case, we are asking what is the history that is critical to make the assessment and diagnosis. Dietary history is the answer. Past medical history is also important, whether the previous history. Immunization is important, right? Okay, especially if they have given rotavirus vaccine and all that might be relevant. History of atopic is important because they have inflection eczema. All this is important, but the critical history for management here is the dietary history, right? So you are quite right in that answer. So let us have the rest of the history. Past medical history. The baby has had 3 episodes of cold and cough, which lasted more than a week since the age of 3 months. From the age of 3 months, he has had 3 episodes of cold and cough, which during the second episode, he had become dyspneic, needing hospital admission. And the diagnosis card issued gave a diagnosis of acute bronchiolitis. Right? The dietary history. The baby was exclusively breastfed only for 2 months. Since the 3rd month, the baby is on breast milk and formula milk alternatively. She is giving every other feed. As the mother felt the breast milk was not enough. So this is no doctor or health worker is guilty for this. The mother and the grandmother have decided. The formula is given by a bottle. At 5 months, she has started semi-solids. And that also, this is a bit of a posh mother. She has gone for a commercially available cereal, not the homemade multi-mix that is recommended in the IYCN. You know what the homemade multi-mix is? No? Right, that is the details are given in the IYCN guidelines. At present, the baby is also given soup and ras moistened with formula. So this is the dietary history and the past medical history. So let's see the question. No, some more. Family and social history. Mother is 28 years old and a housewife, educated up to O level. Father is an executive in a private firm earning 70,000 rupees a month. Mind you, this is in 2019. So this is a fairly good salary at that time. This is their only child. The father has allergic rhinitis and the mother has a history of childhood asthma. And they are also second cousins. They are second cousins. So there is a family history of consanguinity, but not first level consanguinity, what's called second level consanguinity. Investigations done on the ward, the full blood count is within normal limits. No shift of the differential count. CRP is less than 5. The urine full report is normal. The stools show an occasional pus cells and there are no amoebae or cysts. The stool pH is acidic and reducing substances using clinical test is plus. Right? That is called not brick red, but orangish red in the Benedict solution. Right? Okay. So what is the question? Question 5. There are many correct answers. Actually, I can increase the list also. The following are appropriate steps in managing the baby at present. Praneeth, am I exceeding the time? Is there a problem?
And also another 4 to 5 minutes are available because we have started 9:10. You have 15 minutes.
Then I can easily finish. Right. Okay. The following are appropriate steps in managing baby at present. Give 450 ml of ORS by cup and spoon initially over 4 to 6 hours. That is absolutely correct. That is, you are giving moderate dehydration, oral rehydration over 4 to 6 hours ORS, calculated at the rate of 50 ml per kg. Right? He was 9 kg, So 450, that is a correct answer. I'm telling you straight away. Discontinue formula feeds, absolutely correct. He's got lactose intolerance, formula should be stopped. Third one, these are slightly controversial one, but not really controversial. Continue breastfeeding, but less frequently. That is what I recommend. Because even breast milk has lactose. In fact, it has probably as much or more lactose than formula milk. But the hitch is breastfeeding is not something which can be turned on and turned off like a tap. And if you turn off breastfeeding, it might cease completely. So there is a danger of completely stopping breastfeeding. So what we do is we give a little bit of breastfeeding intermittently, but less frequently. This child is malnourished and certainly the little bit of breastfeeding may not be sufficient. So he needs to be topped up with a lactose-free formula. I'm not going to talk about those. There are many lactose-free formula. So now, although we recommend exclusive breastfeeding, that does not mean that you must be clueless about formula feeding. You must be very clueful about formula feeding and what the formulas are available. Formula 1, Formula 2, different formulas, the categories, and the special formulae and all that you must know. So there are many lactose-free formulae. All are expensive, I must say, but these parents have afforded them already. So you can definitely recommend a lactose-free formula. Commencing supplements, no doubt about it, absolutely. Give a probiotic, I think I would go along and say, okay, give a probiotic at least at this stage. Especially this is continue complementary feeding as before, absolutely wrong. Because the complementary feeding she was doing was absolutely wrong. Soup has hardly any calories, right? Rusk is just calories moistened with formula. No, she should be trained how to give the homemade multi-mix. Homemade multi-mix. These details are very well described in the IYCF guidelines. So she must commence the homemade multimix. So A is right, B is right, C is right, D is right, E is right, F is right, only G is wrong, right? Okay, all right. The baby improved. Now this part is a little bit specialist oriented, okay, but I will go through with it. Up to that was entirely for final year medical students and primary care physicians. This is a little bit of a specialist area now. The baby improved with the above management. The stools became formed and he started to gain weight. He was discharged home after 2 weeks on breast milk and a soya-based lactose-free formula. A soya-based lactose-free soya. Pro, Sobi, like that. There are various preparations. And a homemade multi-mix. She was told about how to make a homemade multi. After a further week, as the baby was quite well, the mother reintroduced Formula 2 feeds. The baby is now more than 6 months, so she knows it's Formula 2. She started with the conventional Formula 2 feeds instead of the soya-based formula. Within a week, the baby developed a profuse diarrhea. When she commenced the Formula 2 feed, it commenced a profuse diarrhea. Now, this diarrhea on this occasion is associated with abdominal colic cause. The stools are negative for reducing substances, but show 80 to 100 RBC. So the mother went home, restarted formula instead of the soya-based formula with a conventional formula, and then got a profuse diarrhea with colic and negative for reducing substances, but showing RBC. What is the most likely diagnosis? So I will throw it open. This is, of course, a bonus question. Like if you get it right, you are really good at this. All are plausible. All are plausible, but one is more plausible than the others. Who can give it? Dr. Vikramasinghe? Anyone?
Celiac disease?
No. Okay.
Celiac disease?
No, not celiac disease, because it was not, this
Fibrosis.
area did not start with exposure to a wheat-based thing, no. Like we did not mention home-based thing, it does not contain wheat, no. We don't tell, if we said that the baby has already been on Rust before. So that was, and he has not had, so celiac disease, he has had some failure to thrive, but he didn't have typical disease. It's plausible, but not unlikely.
Fibrosis, sir.
So, yeah, now cystic fibrosis, now I told second cousins and all that. So
Yeah.
therefore, autosomal recessive disorders are more likely in this thing, and the child has, so very good such Govinda gave. What are the points you are telling for cystic fibrosis? He had
Because they are it's a consanguinate marriage.
consanguine marriage, right? Good. What are other
They
points?
have allergic rhinitis and
Allergic rhinitis,
the
not for
mother
cystic
has
fibrosis. No, he had 3
yeah
chest infections. He had 3 chest infections in
chest
early.
infections. Yeah.
Yeah, so that is very much for cystic fibrosis, and but it's not the, so that it is plausible. But those chest infections, one was labeled as bronchiolitis, right? And the mother had introduced
Yes.
cow's milk protein, right? And there is a family history of allergic rhinitis in the mother and bronchial asthma in the father, right? Okay. And the
Yeah.
child
Yeah.
has got this. So what is cystic fibrosis the likely diagnosis? Look at the next option, man. Cow's milk protein
Cow's milk
allergy.
protein allergy.
This child has been, you see, cow's milk protein is much more likely in babies who are exposed to cow's milk early in life. This baby was exposed to cow's milk at 2 months by this mother without even asking a doctor. So the child has had these asthma-like symptoms, which is the first infantile eczema is the first presentation of cow's milk protein in most babies. So this child has had eczema also to some extent, or they can have colic, can be a presentation of cow's milk protein allergy, or they can have blood in the stools. Frank, blood in the stools is a feature of cow's milk protein allergy. He didn't have that at the beginning, but now he's having the moment the mother changed from the soya formula. Now we didn't put the soya formula because he was cow's milk protein allergy. We put the soya formula because the soya formula also is a lactose-free formula. We put it for it being lactose-free. But while it cured the lactose intolerance, when she reintroduced into a formula milk, the cow's milk protein got aggravated. The child is now having a diarrhea secondary to cow's milk protein allergy, and the stool has no reducing substances, it has blood in the stool. And it's not a dysentery or something like that. So that is the correct answer. Inflammatory bowel disease, this child is having diarrhea all the time, and there is blood in the stool now. So inflammatory bowel disease has to be considered, right? Especially ulcerative colitis, but it's not the likely disease, likely thing. Giardiasis, I told you, is a very common infection even in, not very common, it's a known infection even in developed countries or in richer families. And it can cause malabsorption, it can cause diarrhea, it can cause rarely blood in the stools, also not common. So it is all are plausible. Celiac disease is possible. Cystic fibrosis very plausible in this case due to the reasons pointed out by Dr. Sachi Govindagi. But the correct answer here is cow's milk protein allergy. This child has got a cow's milk protein allergy. She was introduced into a cow's milk formula at the age of 2 months by her mother, and now she's showing all the features of a cow's milk protein allergy. I think that's it. So again, any questions about that MCQ? Let's see. Yeah, I think it's only 11:05, so I'm well within my time. So, Praneeth, can we continue the discussion till 11:15, or you want to stop now?
Yes, sir. If you are willing, you can keep for another 5
I am
minutes.
willing to wait till 11:15, but what about the next lecturer?
But sir, today your lecture is the only lecture, sir.
Then I am willing
Yeah.
for another 10 minutes even. Any of the points that came up, either in the case discussion or one of the previous things, you can question me now. Anyone? Any questions? Any clarifications? Any doubts? I told you I am a strong believer in the Kalama Sutra. There you have to decide what to take and what not to take based on what made sense to you.
So can you please give the doses for the batches for the zinc supplementation below 6 months and
I
over
think,
6
yeah,
months?
there is a circular. Again, there is a Ministry of Health circular which is available in every pediatric ward. There is a circular which was sent nearly about 10 years ago, telling zinc, and that gives the details. Unfortunately, in fact, now I am supervising the MSc in human nutrition. There is one girl doing a portfolio on zinc supplements available in the market and which are have the correct doses, which are appropriate to be used in diarrhea. I can't remember the answers. Most zinc supplements available in the market do not have the adequate dose of 10 milligrams. So basically, the government hospitals have a zinc preparation that can be given orally, which has the 10 milligrams. Of the zinc supplements available in the market, I don't know which has, I can't tell you, but you can read the circular and then decide yourself. So sometimes you might have to give, if it is purely the ordinary zinc supplement, you might have to give a higher dose during the diarrhea period, right? You know, the questions you are asking me, I'm telling you, these are the kind of questions which you can use if you want AI or Google to answer. But of course, you have to be knowledgeable because you can get rubbish out of AI and Google if you don't ask the correct question. If you ask a very specific question, like what is the dose of zinc that should be given for prevention of during a diarrheal illness in infancy, you will probably get the correct answer from Google, even, right? Okay. Any other questions or any other points of disagreement or agreement?
Sir, regarding the growth assessment, if the child is growth is going between the -2 SD and -3 SD, and child's mother also earlier his growth also going with -2 SD around -3 SD, is a, we can get is a familiar thing, so we have to investigate for that.
No. The question is whether the curve is flattening. Even if the curve is under 3 SD, like with very severe preterm babies, if it is going parallel, then there is no problem. No. If it is going parallel to the line. So even if it is in the -2 SD, if the curve is going parallel, there is no problem. You don't have to intervene. But of course, in the government regulations, even if the curve is going parallel, if the flow is in the 2 SD, they will give you 3 portion. That's a different thing, right?
Okay.
But you don't have to, your thing is to look at the shape of the curve. If it is going parallel to the centile curve, there is basically no problem. Same applies even to length,
Okay, sir.
right? Okay.
So, in the absence of the further questions, we can call it a day, sir.
All right.
Uh,
Okay. Thank you
yeah,
very much. I really enjoyed it. I hope you benefited from it. Okay.
Yes, sir. I
Thank
want to
you,
thank
Ross.
you for giving us a very comprehensive lecture on care of a child from 0 to 5 years. It has enhanced our bachelor's knowledge as well as attitude and the practice. And thank you very much, sir, again.
Right. Thank you. I enjoyed it.
Thank you, sir. Thank you.
Right. Thank you.